Welcome to the Thanksgiving in-service for the Kent Northwest Kidney Center Dialysis Unit. As I've said before, the greatest dialysis unit on earth. Recently, one of our dialysis patients was found on routine monthly testing to have a positive hepatitis B surface antigen test. And this caused great concern and consternation because of the potential for hepatitis B to spread to other patients and staff. So I thought this would be a good topic to review why hepatitis B prevention is so important for a dialysis unit. Hepatitis B is an infectious disease caused by the hepatitis B virus. It primarily affects the liver and it's classified as a viral hepatitis. Infections can be acute or chronic, and the virus is predominantly transmitted by exposure to infectious blood or body fluids. Today's talk has 4 objectives. We'll review hepatitis B virology. I want you all to appreciate the epidemiology of hepatitis B. It's important to recognize clinical presentation and morbidity associated with hepatitis B. And finally, I want you all to understand preventative strategies in a dialysis unit. Let's begin by reviewing the virology of hepatitis B. The hepatitis B virus is a member of the HepaDNA virus family, so it's a DNA virus. The virus particles consist of an outer lipid envelope, shown in blue, and an icosahedral nucleocapsid core composed of core protein, and that's demonstrated by this green border. These virions are typically 30 to 42 nanometers in diameter, and they're referred to as Dane particles. These are the infectious particles of the virus, so they can cause disease. They are one of the smallest enveloped viruses. The nucleocapsid, shown in green, encloses the viral DNA and a DNA polymerase that has reverse transcriptase activity, which we'll talk about. The outer envelope, shown in blue, contains embedded proteins that are involved in cell entry, and these are the surface antigen proteins, which we will also discuss later. In addition to the Dane particles, which are the infectious versions of hepatitis B, there are also subviral particles that are described as filamentous and spherical based on their shape. They lack a core, so they don't have the DNA core that is present in the Dane particles. So they are not infectious. They are just composed of the lipid and protein that forms part of the surface of the virion, which again contains the surface antigen proteins. So someone who's infected with hepatitis B has both the Dane particles, which are the infectious particles, as well as these subviral particles, which are just the outer coating of the virus, which are not infectious. So hepatitis B replicates by gaining entry into the cell. So first, it binds to a receptor on the cell surface, and then it gets endocytosed or taken up within the cell. Once it is in the cytoplasm of the cell, the DNA of the virus is transferred to the cell nucleus by host proteins called chaperones. Then the viral DNA, which is partially double-stranded, is then made fully double-stranded by a viral polymerase, and it's transformed into covalently closed circular DNA. And then this is a template basically for making new viral mRNA. Okay, so you make this viral mRNA, and that serves as a template to make new virus particles. So you can make all these new virus particles that then can either be released out of the cell to go infect other cells, or they can be broken down and again taken up into the cytoplasm of the DNA to make more virus particles in that cell. Okay, now let's talk about the history of the discovery of hepatitis B, which I find very interesting. So hepatitis B is thought to have come from a wet market run by Neanderthals 50,000 years ago, but not far from where the Neanderthals also had a research laboratory studying the virus. And so there's some debate as to whether or not hepatitis B developed naturally or was man-made by the Neanderthals. No, just kidding. That was COVID virus. But it's true that hepatitis B has been around for a long time. Genomic studies suggest that hepatitis B variant seen in Australian Aborigines has been around for about 50,000 years. More recently, a 2018 study demonstrated the presence of hepatitis B among the remains of a 4,500-year-old human from the Bronze Age. This study also found that some ancient hepatitis viral strains can still infect humans. Another 2018 study of the remains of a mummified child found in the Basilica of San Domenico Maggiore in Naples concluded that the child who had lived in the 16th century had a form of hepatitis B and that the virus was closely related to modern variants. The earliest record of an epidemic caused by hepatitis B was reported by Lerman in 1885. Basically, a couple years early, in 1883, in Bremen, Germany, there had been a smallpox outbreak. And to cope with that outbreak, almost 1,300 shipyard employees were vaccinated with lymph from people who had recovered from smallpox. And after several weeks, and up to 8 months later, 191 of the vaccinated workers became ill with jaundice and were diagnosed as suffering from serum hepatitis. Other employees who had been inoculated with different batches of lymph remained healthy. And so this research subtly showed that the contaminated lymph was the source of the outbreak. In 1909, there was another outbreak of jaundice and hepatitis among recipients of salvarsan, which is an arsenic-based medication used at the time to treat syphilis, and unfortunately the medical personnel kept reusing hypodermic needles among the recipients. But the largest outbreak of hepatitis B ever recorded was an infection of up to 330,000 American soldiers during World War II. The outbreak was blamed on a yellow fever vaccine made with contaminated human blood serum, and after receiving the vaccinations, about 50,000 soldiers developed jaundice. But the big breakthrough for hepatitis B came in the 1950s when a physician at the NIH named Baruch Blumberg, who was a medical anthropologist, was studying the genetics of disease susceptibility. He wondered whether inherited traits could make different groups of people more or less susceptible to the same disease. And so to study this, he went into the world and he collected hundreds of thousands of blood samples from native populations. Then he and his colleagues went back to the lab, and what they wanted to do was to look for genetic differences between the populations. But back then they didn't have the tools to analyze blood samples at the genetic level. So instead, what he decided to do was focus on a particular group of patients who had a disease called hemophilia. Now, patients who have hemophilia have a clotting disorder. They bleed frequently, and therefore they often need transfusions. What Bloomberg hypothesized was that hemophiliac patients would have been exposed to a lot of proteins that were not inherited, okay? So proteins from other people, from other cultures, and therefore they would produce antibodies against these foreign proteins. Now, since antibodies are programmed to lock onto specific antigens, Dr. Bloomberg decided to use antibodies from hemophiliac patients essentially to test blood samples collected around the world. And what he discovered was an unusual match between an antibody from a New York hemophiliac and an antigen found in a blood sample of an Australian Aborigine, which they called the Australia antigen. Then he looked for the Australia antigen in his blood sample collection and discovered that it was rare in America, but it was common in Africa and Asia. Then he tested the patient patient who had hepatitis and found that it also contained the Australian antigen. And then one of Bloomberg's lab technicians, while working with the samples, developed clinical hepatitis and was found to have the Australian antigen. So it turned out that the Australian antigen was the hepatitis B surface antigen. In 1970, David Dane and others discovered the virus particle by electron microscopy. And in 1971, the FDA issued its first ever blood supply screening order to blood banks for hepatitis B. In 1975, Dr. Bloomberg won the Nobel Prize in Medicine for the discovery of hepatitis B and development of a vaccine against hepatitis B. In the 1980s, the genome of the virus was sequenced and the first vaccines were being tested. All right, now let's discuss the epidemiology and clinical presentation of hepatitis B. So about a third of the world's population, about 2 billion people, has been infected at one point in their lives. In 2017, at least 391 million people, or 5% of the world's population, had chronic hepatitis B infection. And 145 million cases of acute hepatitis B virus infection occurred that year. Now, the prevalence of chronic hepatitis B varies throughout the world and is highest in Africa, up to 15% of the population. Over 750,000 people with hepatitis B die each year, and about half of those are due to liver cancer. So what's the prevalence of hepatitis B in North America? Well, it's about 0.7%. And the prevalence among dialysis patients in North America is about 0.2%. And that's down from 6.2% in 1974 because of all the efforts we've made to reduce the transmission of hepatitis B in dialysis units. Most patients with an acute hepatitis B infection are asymptomatic. About 70% have no symptoms, but that means that 30% of people do if they have hepatitis B infection. And they typically present with fever, malaise, just feeling horrible, loss of appetite, other GI symptoms such as nausea and vomiting. They may have joint aches, body aches, dark urine, and jaundice. Jaundice occurs when people's skin turns yellow, and you can also get what's called scleral icterus, as demonstrated in this photo. The illness usually lasts for a few weeks and then gradually improves in most affected people. A minority of patients, however, may develop acute fulminant liver failure from which they can die. So it can be a life-threatening infection. Chronic infection also is often asymptomatic, so most people have no symptoms when they have chronic infection. But symptomatic disease can develop, particularly in the long run, in the form of cirrhosis and liver cancer. So a lot of these patients go on to develop end-stage liver disease. And hepatitis B, even though it lives in the liver, it can cause disease outside of the liver. So people can get inflammation of the blood vessels called a vasculitis. They can also develop kidney disease. So there are millions of people in this world who have kidney failure on the basis of hepatitis B. And it can cause various inflammatory kidney conditions such as membranoproliferative glomerulonephritis or membranous nephropathy. So how is hepatitis B transmitted? Well, as I suggested earlier, it results from exposure to infectious blood or body fluids containing blood, and it is a very infectious virus. It's 50 to 100 times more infectious than HIV. If you get poked with a needle that's infected with or that's contaminated with hepatitis B, you almost certainly will get hepatitis B that way. And it is a very hardy and durable virus. So the hepatitis B virus can remain viable on a surface for at least 7 days. In dialysis units, it can be on clamps, it could be on tubing, it could be on scissors, it could be on machines, it could be on doorknobs, etc. So in general, hepatitis B is transmitted by exposure to blood products, but there are some specific examples of this. For example, childbirth, when the mother gives it to a baby at the time of birth. Biting, if a kid has hepatitis B and bites another kid, that can do it, or if scratches with fingernails. And so kids, particularly in endemic countries where there's a lot of hepatitis B, can pass hepatitis B to one another. Sexual contact, of course, can transmit hepatitis B. Intravenous drug abuse, transfusions of blood. We screen the blood, that's transfused, although that doesn't mean that the screening process is perfect. And of course, in dialysis units, as we discussed, hepatitis B can be transmitted. As an aside, you cannot get hepatitis B by holding hands, sharing eating utensils, drinking glasses, kissing, hugging, coughing, sneezing, or breastfeeding. How hepatitis B is transmitted in part depends on geography. So in low prevalence areas such as United States and Western Europe, it's typically transmitted through IV drug abuse and unprotected sexual intercourse. In moderate prevalence areas, Eastern Europe, Russia, Japan, where 2 to 7% of the population is chronically infected, is primarily spread among children. So you have a lot of kids who have it, and then they hang out in school, or they, bite each other, scratch each other, play with each other rough. That can transmit hepatitis B. In high prevalence areas, China and Southeast Asia, transmission during childbirth is most common. And in endemic areas, high endemic areas such as Africa, transmission during childhood. Again, kids playing with each other in a rough fashion is the most common mode of transmission. I mentioned earlier that dialysis units used to be a common source of exposure of hepatitis B, and that's because hepatitis B is present in extraordinarily high titers in the blood and other body fluids, so more than 1 billion virus particles per milliliter. As I said earlier, very hardy, can live on surface for at least 7 days. And in the old days, when dialysis staff didn't take all the precautions that we do, wipe down everything with bleach, wear gloves, etc., then it was pretty easy to transfer the virus from patient to staff and to other patients. Risks for transmission hepatitis in dialysis units include if you have a patient with hepatitis B surface antigen within the same dialysis unit. If you don't have a dedicated machine, so if you share machines, that's a big no-no. And if less than half of the dialysis population of that unit is vaccinated, and some units around the country have low rates of hepatitis B vaccination, but that is not, of course, the case for the great Kent Northwest Kidney Center. All right, now let's talk about the diagnosis of hepatitis B infection. The most frequently used test to screen for the presence of hepatitis B infection is the hepatitis B surface antigen located on the surface of the virus envelope. It's the first detectable viral antigen to appear during infection, and it disappears if the infection is cleared by the host, but it persists if the immune system is unable to eradicate the virus. The hepatitis B core antigen is shown in red in the diagram, and it encloses the viral genome. It appears next and, in some cases, is the only serologic evidence for disease. It is highly immunogenic, so it's very good for stimulating antibody production. And that's why most hepatitis B diagnostic panels contain both hepatitis B surface antigen as well as antibody against the hepatitis B core antigen. Okay, shortly after the appearance of the hepatitis B surface antigen, another antigen called the hepatitis B E antigen will appear, and that's demonstrated by these green X's. Basically, its presence is often associated with much higher rates of viral replication and enhanced infectivity. That's not true for all variants of hepatitis B, but for many of them. And during the natural course of infection, the hepatitis B E antigen may be cleared, and then the patient will develop antibodies against the E antigen. Next, the body will hopefully make hepatitis B surface antibody. These are neutralizing antibodies against the hepatitis B surface antigen. They also develop in the setting of immunization. So when we give someone the hepatitis B vaccine, we check to see whether or not they've developed the hepatitis B surface antibody. If a patient is unable to clear the hepatitis B surface antigen over a 6-month period, they become diagnosed with chronic hepatitis B. And at that point, we can send them for what's called a polymerase chain reaction test. It's a test used to detect the DNA, the hepatitis B DNA in the blood. So if someone has active infection, they will have a positive PCR test. All right, now let's discuss the prevention of hepatitis B infection. CDC has many recommendations regarding hepatitis B for dialysis units. First, all patients and staff should be vaccinated against hepatitis B. Second, we check for the hepatitis B surface antigen in all dialysis patients at least annually. And if someone does not respond to the vaccine, so they don't develop the hepatitis B surface antibody, then we will check them monthly for the hepatitis B surface antigen. If they have hepatitis B surface antigen, then they need to be dialyzed in an isolation room, and at the Northwest Kidney Center, it's either in SeaTac or in Burien. If you're taking care of a hepatitis B patient, you can't take care of a non-hepatitis B patient, so there's no shared staff during the shift. There's no shared dialysis equipment between hepatitis B positive and negative patients. And of course, as with all dialysis patients, we wear gloves if we contact patients or equipment, and we change the gloves in between patients. We use lots and lots and lots of bleach in dialysis units to make sure that we kill not only hepatitis B, but lots of other viruses. As I mentioned earlier, hepatitis B vaccination is recommended for all staff and all dialysis patients. And after you administer the vaccine, you can check them for the presence of the hepatitis B surface antibody 1 to 2 months after the last dose. If it's immeasurably low, then we revaccinate our dialysis patients. And if it's elevated, then we consider the patient immune and retest them annually. If the titer falls below 10 MIUs per mil, then we re-administer a vaccine and retest them annually. The hepatitis B vaccine was developed by the man who discovered the virus, Dr. Bloomberg, and essentially what it consists of is a high concentration of hepatitis B surface antigen. So that's administered to a patient, and it stimulates antibody production. It's been routinely recommended for babies in this country since 1991, and ever since we've used it, we've seen a reduction in hepatitis B cases among children and teens by 95%. So it's a very effective vaccine. And it appears that protection is long-lasting even after antibody levels fall below 10 milli-international units per mil. That said, even if someone clears a viral infection, it can reactivate. So the hepatitis B virus DNA remains in the body after infection, and rarely, particularly among patients who are immunosuppressed, including dialysis patients or patients who have received chemotherapy or receive immunosuppression, or among people who use alcohol or drugs, the virus can reactivate. And hepatitis B in someone who has chronic infection can go through cycles of replication and non-replication. So even carriers can experience acute reactivation of hepatitis B. The risk of reactivation varies depending on the serologic profiles. If you have hepatitis B surface antigen in the blood, you're at the greatest risk of clinical reactivation. Those with antibodies only to the core antigen are also at risk. The presence of antibodies to the surface antigen does not necessarily preclude reactivation. So if you previously had the infection and you cleared it, again, if you become immunocompromised, it could still reactivate. We do have antiviral medications now that are very effective in preventing reactivation. So with all the precautions and understanding of hepatitis B transmission that we have, why does hepatitis B still occur in dialysis units? Well, if we don't screen our patients annually, if we fail to review the results, if we don't segregate the positive and negative hepatitis B patients, if we use multi-dose vials, that is, if we had one vial and we kept drawing Mircera out of it, for example, and administering to multiple patients, and finally, if patients refuse to get vaccinated, I mean, if we have vaccination rates of less than 50%, that increases the odds that you're going to have an outbreak in your unit. So back to our patient. So one of our patients earlier this month had a positive hepatitis B surface antigen test. So he was dialyzed at the end of the day in the last chair of the row with a machine that was subsequently bleached. A hepatitis B PCR was sent and was fortunately found to be negative. So he did not have any hepatitis B DNA detected in his bloodstream. And then we repeated the hepatitis B surface antigen, and it was negative. So the previous test that was positive was considered to be a false positive. Unfortunately, he was allowed to return to his regular dialysis chair in our unit. So why do false positive hepatitis B surface antigen tests occur? Well, the main reason by far is because of the hepatitis B vaccine. So up to 50% of people will have hepatitis B surface antigen detectable in the serum after vaccination. Recall that the vaccine is comprised of a high concentration of the surface antigen. So if we administer it to a patient, it kind of follows logically that we might be able to detect that in the serum. So that will cause a false positive hepatitis B antigen test. Patients who have autoimmune disease like lupus and rheumatoid arthritis have also been shown in some cases to make antibodies against hepatitis B surface antigen, another example of a false positive. And just for fun, there was a case report reported where a patient had a parathyroid adenoma with a false positive hepatitis B surface antigen. It was removed and the antigen cleared. Okay, time for our monthly quiz. Question 1. How many people in the world have been exposed to hepatitis B? That's right. 2 billion and counting. So more than 25% of the world's population has been exposed to hepatitis B. What kind of disease does hepatitis B cause? Excellent. Cirrhosis and liver cancer. Those are the primary two primary diseases which it causes. But again, it can also cause extrahepatic disease, such as vasculitis, so-called polyarteritis nodosa, and kidney disease, either membranoproliferative glomerulonephritis or membranous nephropathy. How long can hepatitis B live on surfaces outside of the body? That's right, at least 7 days. So very hardy virus, and that's why we have to be afraid of it in dialysis units. Which is more infectious, hepatitis B or HIV? You got it, hepatitis B, 50 to 100 times more infectious than HIV. Again, more than a billion infectious viral particles in 1 milliliter of blood. Final question, what is the most common cause of a false positive hepatitis B surface antigen test? You got it, hepatitis B vaccination. So we give people the antigen, and it follows that we might be able to test for or detect the antigen in the blood. Since this is a special Thanksgiving edition of the monthly Kent Northwest Kidney Center, I just want to extend a heartfelt thanks to the wonderful staff of the unit who make this unit so great. This is Andy Brokenbrough, signing out until next month. Have a happy Thanksgiving.